Yeah, as I said earlier, and as you heard from my friend Dr. Claudette Chase, that the primary healthcare system that we have in First Nations communities is at the nursing station. And nurses employed by Health Canada do not have the scope of practice to engage in supporting First Nations people in their own community in addressing opiate issues beyond 30 days. That's one point. The second point is that we don't have access to treatment for opiate addiction. And when there is access, it's short term. Without access to treatment, many people are suffering in their communities, which leads to illicit drug use. Okay. And the problem continues. And I'm thankful that you mentioned Southern Alberta, because I also want to say that the research on addiction says that it's permanent brain damage and it can't be undone. And I think that that's a racist way of keeping people on methadone, because people in Indigenous communities have had to leave their communities to access treatment, and the primary course of treatment has been with methadone by physicians who say it's a course of treatment for the rest of your life.
Thank you. You touched a little bit on naloxone. To your knowledge, do all First Nations communities have access to naloxone to treat opioid overdose? And also another one, and have there been any difference in how this crisis has been felt by the urban versus rural population? What are the differences or similarities when facing this crisis? So those two questions.
So access to buprenorphine naloxone has been a challenge for First Nations communities. We have been successful in getting some greater access to buprenorphine naloxone. It's by exception on the non-insured health benefits, and then in provinces like Ontario, the Minister of Health has just announced greater access. The program that Dr. Chase is talking about is successful because it uses buprenorphine naloxone. And so I would encourage that buprenorphine naloxone has to be the first line of treatment for Indigenous populations with an opiate addiction, because it allows them to stay in their community, and it allows for a team-based approach. And Health Canada has to change its policies around nursing in communities so that it's a strength-based primary care program and not a nurse program, so that they can work with others in communities. The other question you had, I'm not sure that I answered. The naloxone kits are not widely available, that's true. We need greater access to naloxone, and we need support for broader distribution to high-risk populations for naloxone.